how pressure changes from atmosphere to cell. That is called oxygen cascade. So in the atmosphere it is 160, 159. Then in the trachea it is 150. Why it is reduced to 150? Because of humidification. Humidification in the nasopharynx. Pressure is reduced to 150 in tracheum. In alveoli, it is around 100, 99 to 100. That is because of dilution by the carbon dioxide. Because of dilution by the carbon dioxide, the alveolar pressure is around 99 to 100. This alveolar pressure, alveolar oxygen pressure is equal to end capillary, pulmonary end capillary pressure. Pulmonary end capillary pressure is same as alveolar oxygen pressure. That is around 99. In the arteries, systemic arteries oxygen pressure is around 92. This alveolar and arterial oxygen pressure gradient is important. Alveolar, capital A. Capital A is alveolar pressure minus small a is arterial pressure. We will check PaO2 in AVG is arterial pressure. So here arterial pressure is 92. So the alveolar to arteriolar pressure difference is very important. Okay, that is 92. This is PaO2, the arterial. Coming to the venous part, PvO2 is 40. Venous oxygen pressure is 40. What is the tissue pressure in the interstitial tissues? What is the tissue oxygen pressure? That is called PTO2. Interstitial oxygen pressure. That is around from 15 to 35. Generally it is 15 in most of the tissues, but in brain it is 35. Maximum tissue pressure will be in the kidneys. Okay. Should know interstitial tissue pressure. Then oxygen enters into mitochondria. In the mitochondria, it is 5. In mitochondria, oxygen pressure is 5. With oxygen utilization from 1 to 5. So from 160 pressure in the atmosphere, pressure decreases to 1 to 5 millimeters of mercury in the mitochondria. This is oxygen cascade. FiO2, sir said FiO2 more than 60 is toxic to cells. FiO2 more than 60 is toxic to cells. We can't maintain FiO2 100% for more than hours or for few days. There will be systemic inflammatory reaction. High oxygen is toxic to cells. Human cells, they prefer low oxygen environment. We are microaerophilic organisms. Cells prefer low oxygen environment because in the mitochondria it is 5 mmHg. In the interstitial tissues it is 15 mmHg. So cells prefer low oxygen environment because high oxygen pressure is toxic to the cells. We should know about oxygen toxicity. How oxygen is toxic to the cells. That is oxygen metabolism. In oxygen metabolism, there are 4 steps for the conversion from oxygen to water. Do you know those 4 steps? Oxygen metabolism in the cells. In the mitochondria, through electron transport chain, there are 4 electron reduction reactions. First, oxygen, molecular oxygen is converted to oxygen free radical. Superoxide, with one addition of electron, it is converted to superoxide. It is free radical. It damages cells. From superoxide, with addition of 2 hydrogen ions and another electron, it is converted to hydrogen peroxide. From hydrogen peroxide, it is converted to hydroxyl ions and hydroxyl ions and free radicals. This is called hydroxyl free radical. These two are dangerous, superoxide free radicals and hydroxyl free radicals. And it is converted to water. So high FiO2 is dangerous to the cells. That we should know. We shouldn't keep the patient with FiO2 100% for more than at least for more than 6 hours. It is very dangerous to the cells. This is about oxygen cascade and oxygen toxicity. Here ceruloplasmin and transferrin, they cause reduced iron to oxidized iron. They have antioxidant properties. H2O2, this hydrogen peroxide is converted to water by glutathione metabolism. Selenium glutathione enzymes, they convert it to H2O. If we give N-acetylcysteine, NAC, through glutathione metabolism, this H2O2 will be converted to water. These are some steps in oxygen metabolism regarding oxygen toxicity. For indications of ventilation, most important is work of breathing. The work of breathing is more, that is an indication for ventilator. You can remember diaphragm. Some clues for increased work of breathing is one, diaphoresis. There is increased sweating, that is a clue for increased work of breathing. And heart rate, increased heart rate and hypoxia. Along with hypoxia, even increased heart rate, it is a clue for increased work of breathing. When patient is on supplemental oxygen, if heart rate is more than 130, it means work of breathing is more. In the respiratory tachypnea, respiratory alternance, paradoxical breathing, tracheal tug, they all indicate increased work of breathing. G for gasping. If patient is gasping, we need not look for any indication. We can directly intubate the patient. So gasping. Axillary muscles. We should always look at axillary muscles. Look for nasal flaring. There is a work of breathing scale, that is called WOBs. Work of breathing. Each point for on axillary muscle action. Look at LNASA, the nasal flaring, that is point 1. Look at sternocleidomastoid muscle head and inspect and palpate. They are tense during inspiration, means work of breathing is more. Look at abdominal muscles during expiration. Again, inspection and palpation. Look at intercostal muscles. Axillary muscles involvement means work of breathing is more. And respiratory rate from 20 to 30, if it is increasing from 20 to 30, again work of breathing is more. So even in indications, even PaO2 by FiO2, PaO2, they are the main indications. But most important is whenever there is increased work of breathing, we should plan for early intubation. Some indications are if PaO2 less than 60, we can wait up to 60, PaO2 60. If PaO2 is less than 60, even with supplemental oxygen, or PaCO2 more than 55 with pH less than 7.25. If vital capacity is low, less than 15 ml per kg, if minute ventilation is more, 10 liters per minute. So there are many indications for planning for intubation.